Welcome to our CFC meeting this morning. Today, Dr. Yao would talk about the reoperative orthognathic surgery. This is a very important topic for a clinical surgeon who are doing the orthognathic surgery. So let's welcome Dr. Yao. Dr. Yao, please.
Yes. Hi, good morning, everyone. Wait a minute, I should put to full screen. Okay. Oh. Sorry, wait a minute. Okay, today I mainly do literature review. Actually, I will present this topic at the forum this year, so I think myself should do some literature review. But today I think I collect about 6 to 7 articles in recent years, and I just complete reading 2 of them. But I believe that's a relatively important article, so I will just present 2 articles for today's presentation. So the first comes from Posnick. We know that Posnick is quite famous surgeon in United States, and he have his own textbook about orthognathic surgery. So this is an article published 2019. This is a retrospective study, single surgeon by Posnick, and actually Posnick have quite abundant amount of publication in JOMS. So he have show his outcome by showing the day of hospital stay, the complication of back split or the lingual nerve injury. So that's some of his publication in past several years. So I believe that maybe he read the article I will present later from a European surgeon, and then he proposed to present his result in this article. So basically, his case was from year 2001 to 2017. So in consideration of the time span, you know that relatively it's not a common situation that you do a redo OGS. And of course, he exclude all the syndromic cases, which means that he exclude all those with congenital anomaly. He exclude those with bone tumor or TMJ problem or post-traumatic situation. And basically, he make a term of redo OGS. Later, I will have some discussion of the term of so-called redo, or it's just a take back OGS. And the 10 cases he present here are all done by the primary was all done by outside provider. Okay, so there's some special feature that I think it's always easier to present some other the secondary case whose primary was done by others. And if you want to differentiate between the so-called take back OGS and redo OGS, basically you select someone who received reoperation 1 year after the primary procedure. And all of them have perioperative orthodontic treatment. And a special feature in this, in Posnick's evaluation will be the upper airway evaluation. So he put, here are several terms here. First is so-called CONB, is chronic obstructive nasal breathing. Chronic obstruct, so which means a chronic nasal obstruction. Second is sleep disorder breathing. So if you have any doubt of sleep disorder breathing, basically we will arrange a polysomnography for the patient before surgery. And they collect, of course, the demographic, anatomic, operative variables. Actually, in this article, he wants to test the null hypothesis that redo OGS in comparison with primary OGS does not really have like such as longer operation time, have more surgical complication, have more uh, perioperative complications. So here are the variables he collect: the demographic, age, gender, anatomic means the pattern of dental facial deformity. Is there any presence of nasal breathing problem or OSA? And the situation of the dental occlusion. For the operative variables, he record for every case the planned vector change. So the vector change here actually means uh, the change in 3 degrees of freedom. So the sagittal, the vertical change, and also the roll and the pitch. And he also include that for the redo procedure, does maxillary segmentation is required for the redo operation. For the outcome variable, he record for every patient the first operation time, which means the open wound time and from incision to the last stitch. The second is does blood transfusion is necessary within 30 days of procedure. The third is length of hospital stay. The fourth is the airway, any special airway issue perioperatively. For the complication, he compared this series to his previous published series uh, in these aspects. First, back split, lingual nerve injury, surgical site infection, and dental injury. For result, actually, if this is relatively small series, 10 case, so he lists quite detail the situation by several different tables. So this is I think the baseline situation. And I think a special thing here will be case number 7. So the age at first surgery is 13. However, and and also case number 4, the age at first surgery is 15. However, he mentioned in the material method that basically he collect only those who receive primary procedure at skeletal maturity. So this is something I'm a bit confused about the selection criteria and the real case presented here. And a second thing here is that for all the case that he do redo, basically all the patients have occlusion problem. So this could be something a bit different from our case because sometimes we do redo operation out of aesthetic reason. I mean, most of us, I think at least half of our redo does not have really any occlusal problem, mainly are aesthetic concern. And here you see the first orthognathic procedure. Actually, there are 3 cases. They do not really receive a conventional two-jaw surgery. It's a surgical assisted rapid plateau expansion. I believe that this redo procedure is relatively rare in his practice. So he need to include those who receive this type of surgical assisted rapid plateau expansion into his series. And here is the second table. So he presents here that the more occlusion situation before the redo procedure. So basically the same thing that all the cases have uh, some degree of a real occlusal problem. And another special feature of this series is I think Dr. Posnick put big emphasis on the either nasal breathing evaluation or OSA evaluation. So here within the 10 case, there are 2 patients with obstructive sleep apnea, and there are 8 out of 10 have uh, some degree of nasal breathing problem. So he, in response to those airway evaluation, I think basically the last column is the surgical procedure he do. So for those who have nasal breathing problem, he will do septoplasty and turbinate reduction at the same time. So this is a quite special, I mean, philosophy of this surgeon. And these 2 tables, you can see how he make a quite detailed evaluation and record of the patient's occlusion. So the table 3 is an occlusion before redo, and the table 4 is the okay, the table 4 is the planned skeletal change. So all these 2 was considered to be the anatomic variable and the operative variable that relates to the treatment outcome. So from table 3, you see quite detailedly he evaluates the incisor over J over by the canine angle classification, the posterior, the posterior means the first molar. First molar either vertical or transverse more occlusion. And for table 4 shows the surgical move. So here we can notice in his series, uh, every case have maxilla advancement. So the advancement range from 1 millimeter to 11 millimeter. And for mandible, also all the case receive, all except 1 case receive mandible advancement. So this is a quite, I think, quite special situation because their patient population, most of time they consider skeletal expansion movement to have better soft tissue support. And here shows the, I think this is the so-called outcome variable. So the outcome variable in this table 5 shows first the operative time. The red word is a comparison that in this series, the mean operative time is longer than his previous primary OGS series. So for redo OGS, he takes longer time. Average is 3 hours, 36 minutes. And his primary series, the average operative time is a bit less than 3 hours. So it's about 37 minutes longer if he do a redo procedure. And for the perioperative airway problem, the place of extubation, any airway events, the requirement of blood transfusion, basically there is almost a perfect situation in this 10 reoperative cases. And for hospital stay, there is only 1 patient need a 3 nights stay in hospital, and most of his patient 2 nights stay in hospital. So this could be quite similar to our situation. We most of time we have 2 nights stay after our orthognathic surgery. So there is almost no complication in the hospital readmission. There is no. So there is another outcome analysis. Again, he do a so-called occlusion analysis. So the occlusion analysis could be done like a short-term occlusion outcome. So this shows in table 6. And table 7 is a long-term occlusion. So he used the same seven item to check the occlusion 5 weeks after, or the long term means more than 1 year after surgery. So here in table 7, we see there is only patient number 5 that have residual occlusal problem after redo surgery. So in his series, there is only one patient who have residual more occlusion after redo OGS in the long-term follow-up. So in conclusion, patient who receive redo OGS require a longer operation time, and hospital stay major complication similar to primary. And so the redo OGS will still successfully achieve and maintain a correct position in most cases. The last, for this article, I think I like to make I consider something that's important to myself, that first he defined the take back with redo. So redo means, this is an important definition, that redo means the secondary reconstruction after healing of primary osteotomy. So if you want to, if we want to collect our redo OGS case, basically you should collect some case who receive secondary procedure after healing of primary osteotomy. And in this series, basically he collect those who receive secondary procedure more than 1 year after the primary. So for the take back, he defined it as a carry out for a recognized complication before the healing of the osteotomy. So could be that could be due to infection, hardware problem, fibrous union, or facial aesthetic problems. So for diagnosis evaluation of those who may require a redo procedure, I think basically we will evaluate occlusion, the aesthetics, and in this Posnick series, he put quite a large emphasis on the nasal airway and OSA problem. And he doesn't really pay attention too much to the TMJ problem, but we can notice from the result that actually some patient may complain TMJ problem after redo procedure. And to me, I think the occlusion records in this report, I think to me is quite comprehensive and quite detailed. So if I want to conduct similar study, I think the occlusion record should be at least as complete or as detailed as possible. I think that for the definition of so-called suboptimal outcome, or the threshold when we determine to design, when we determine to do a redo OGS, it is still something that is quite subjective for either the surgeon, for the orthodontist, or for the patient. Then we can go to the second procedure, I think, which provides some, I think to me, more importantly, provides some insight for the patient selection. So this is the article published 2018 by Dr. Ruffini. He is a surgeon in Italy, in Europe. And this is a relatively big series of 70 consecutive cases. First, I think this series is different from Posnick's series by actually he put more emphasis on the so-called aesthetic either evaluation or he do Tujo OGS to improve the suboptimal aesthetic outcome. So he shows here is some table from the introduction that you may evaluate the patient either in frontal view or in profile or three-quarter view he lists all the possible aesthetic defect after the primary OGS. So from the jaw, the chin, facial asymmetry, hourglass chin deformity, the mandible angle, the mandible contour, deep teeth relation while smiling or speaking, the teeth show excessive or deficient, the gummy smile, the dental arch, the soft tissue. For Caucasian, I think they worry more about the sagging, the aging appearance, the downturning mouth angle. So also the nose is something quite close to our two-jaw procedure. So the nasal change is also a major cause of suboptimal aesthetic outcome. So here are something that tell you your patient may be unhappy about the aesthetic outcome. And these are all the lists of the possible source of unsatisfactory aesthetic outcome. And here shows the basically he wants to categorize the source of the suboptimal aesthetic outcome by either maxillary, mandibular defects, chin defects, or the soft tissue defects. So the type of defect, the cause of the situation. So for example, if you look at the short face, it could be in the first procedure, an over impaction of the maxilla. So for the redo procedure, basically you consider the 4-1 down grafting. So these are all the possible situations you may face in the redo procedure. So I think this is a good review if you want to take a detailed check, and we'll give you a brief idea what to do to design the secondary procedure. Here are the complaints from his 70 cases. So the all number, if you add it up, it's more than 70. So which means that the one patient may complain more than one thing. So 55 patient complain. Here is I think this is so 55 patient complain facial asymmetry, and 24 could be excessive prominence of paranasal maxilla, 15 poor prominence of two-jaw, and 11 insufficient upper incisor show and too prominent lower chin. 8 belongs to mainly the chin parasymphysial complaints. So here are the prevalence of the different types of defects. So here is a table that based on the 70 redo OGS cases, he shows what the patient complains. So one patient may complain more than one thing. So here are the possible problems, the aesthetic problems that appears in the patient. So here I'm going to show the material method, and very interesting thing I can get some ideas of how we may be able to do our patient selection. So from year 2006 to December 2015, based on the main surgeon's private clinic, all the procedure primarily done elsewhere. And basically he sent the 2013 cases is someone who is not satisfied with the primary procedure. So this surgeon sends to all the patient to see psychologist. Okay, so this is something important. So he will, and then he personally will compare the aesthetic complaint from the patient with the objective aesthetic analysis of the surgeon. Okay, so the 230 case, then he exclude or he reject 12 because 12 patients have psychotic tendency or unstable psychological problem. He reject another 26 because they are diagnosed with body dysmorphic disorder, which means that they may have a objectively minor aesthetic problem, but they consider it to be a major. And he also rejects 13 who have unrealistic expectation. So end up to be 179. So he defined this 179 patient to be someone who have a real poor aesthetic result, and they also have a sound psychological status. So the first step, you exclude those who have some psychological problem, okay? And then you have this group of patients, then you provide your surgical treatment to them. And out of the 179 patients, 104 patients, they do not want to have a major two-jaw procedure. They accept only minor procedure. So this means that surgeon consider important, but the patient doesn't really want redo major two-jaw surgery. And 5 patients, because of some personal problem, they do not receive a real complete treatment. So end up, there is 70 cases included in this series. So all the 70 patients, finally they receive redo two-jaw OGS in this series. So this would be about 30%. So about 30% who receive primary OGS in else place, who comes to you, the rate that you do redo OGS in Dr. Raffani's series is about 30%. So of course, more female, 52 and 18 males. Average age is 25. And within this series, there are 5 patients who previously treated with surgery first approach. He do only, okay, the series actually started from 2006. It's really early, till the 2015. So before, from 2006 to 2009, basically he does not started doing 3D simulation. So Dr. Raffani started to do 3D simulation from year 2019, and he do 3D print, intermediate sprint from year 2013. And for the 70 cases, he do two-jaw surgery plus simultaneous. For 100% of case, he will do at the same time facial fat graft. Okay, so two-jaw with 100% fat graft to the face, and 40% genioplasty, 64.3% rhinoplasty, and 2.8% angle processes. And again, so all the patients receive secondary more than 1 year after primary. So the outcome evaluation basically should be relatively long term. So at least 1 year after reoperation, he do for the outcome presentation, he do objective outcome evaluation and subjective outcome evaluation. So the objective outcome evaluation is done by 2 surgeons and 2 orthodontics, who is now the treating physician. So who is so the Dr. Rafani himself, he did not do the objective outcome evaluation. And for the subjective outcome evaluation, it's based on a scale that the patient will respond to, the so-called aesthetic numeric analog scale. So this is a 11 scale evaluation, subjective evaluation by the patient. So the higher the score means the higher the satisfaction. So for the results, he said each patient achieved class 1 occlusion. Of course, he doesn't put too detailed detail about how he do the occlusion evaluation, like the Posnick series. And 3 patients have TMJ disorder after surgery, and there is no major complication. Some minor complications. So he defined intra-op bleeding as more than 300. Okay, this is a small number, so about 15 cases. And there are 2 patients need hematoma, cheek hematoma drainage within 3 days. And 5 patients have a permanent loss of inferior alveolar nerve sensitivity. So he present here that because these 5 patients have a previous bicortical screw, which is put quite close to the mandibular foramen, and we know that if you do a redo procedure for those who receive bicortical screw fixation, basically you need use your saw to cut through the previous bicortical screw, because the canal is closed, so the nerve is injured. So this could be a permanent loss. And 29 patients, 40% have a periodontal problem. So for the objective evaluation, basically more than 90% have aesthetic improvement. So the higher score means the higher objective evaluation. So for the there are the most patients, 34 was score 5, which means it's very objectively evaluated by the clinician, is considered to be quite successful. And there is about 5 case that is considered to be no improvement or even some minor drawbacks of the secondary OGS. So from the patient's subject perception, there is 3 patients unsatisfied, and all of them affected by TMJ disorder, and more than 90% was satisfied with the results. So the conclusion, the secondary OGS in conjunction with facial fat injection will lead to satisfactory aesthetic outcome, and propose an accurate selection of patient and meticulous 3D planning and appropriate intraoperative maneuver. So some important ideas from this article, I think for the redo procedure, I think we will really need a psychologist to help that, to make sure the patient is psychologically stable, no body dysmorphic dysfunction, and we can operate on those who have the aesthetic complaints match our objective aesthetic analysis, and the patient should have a realistic expectation. The patient should have a sound psychological status, And of course, the patient need to be willing to accept a major redo OGS. And as a surgeon, I think to optimize the aesthetic outcome, we should consider some adjunctive procedure like fat injection, rhinoplasty, or something more to improve the aesthetic outcome. So from here is the last slide that from these two articles, I think some lessons I learned. The first, I think we need to admit that threshold or indication for redo OGS is quite subjective. Either for the patient, orthodontist, or for the surgeon. I think three, either the patient, the surgeon, also the orthodontic could have their own personal idea about whether we should proceed for a redo OGS. But I think as a surgeon, we should, before we really go to the redo Tujo OGS, we should have a really complete patient evaluation. The psychologically, I think this is something that I never refer patient to psychologist. So I will try find someone that if for the patient who have suboptimal outcome after first procedure, who comes from other primary surgeon, I will consider find a cooperative psychologist. And from Posnick's article, he put emphasis on airway. I think airway is always a problem, and with the patient aging or the inadequate soft tissue support of, you just add some simple question in your clinical evaluation that if any doubt, you just send a patient for the polysomnography. It's important. TMJ always something that is related with dental facial deformity, and of course, I don't think we most of the time we just focus on the dental facial improvement. For TMJ, we still need either Arthur our colleagues to help us, or some TMJ specialists that you need to clarify the TMJ problem before you redo OGS. And for treatment, I think basically we do Tujo surgery, and now I think in our routine we already do a quite sound pre-op evaluation. For every case, we do a 3D planning, and to optimize the aesthetic outcome, we should consider some adjunctive procedure. Because we are plastic surgeon, we should find out something that we may do at the same time to achieve the best outcome. Okay, so this is my presentation. So I hope there could be some comments and discussions from other surgeons. Thank you. Or orthodontics. Thank you.
Thank you, Dr. Yao. Is there any comments or questions? In the two literature review, actually we see the two article actually focused on a little bit different in their reduced surgery purpose. So sometimes patients they come to our clinic sometimes because of aesthetic and sometimes because of other reasons. So for Dr. Yao, after reviewing these two articles, what would you say about when you see a patient coming from other surgeons' clinic and then saying that the previous surgeon did something not so good to the patient, and then maybe they complain about aesthetics. Sometimes not so many patients complain about the airway. So sometimes it's difficult to accept one patient that coming from other surgeons and then having some unhappy experience. So what would you say? What would you say about the first contact with those unhappy patients? What's your opinion about the importance of the evaluation, and what would you do after reviewing these two articles?
I think after presentation, I forget something. That first, I need to thank Professor Ray Chen. Basically, I before answering the question from Professor Lin, that I learned everything from Professor Chen, and I remember my when I started learn OGS, I attend all his clinic every Wednesday and Friday. And then from year 2019, actually he bring me to Xiamen, Changgeng, and in his clinic, all the patients from all around China who is unhappy about the primary OGS comes to Professor Chen's Xiamen VIP clinic. So I think all my thinking or thoughts will comes from Professor Chen. And of course, after reviewing these two articles from two very experienced surgeons, we have some special thoughts. But maybe I will change. But right now, I am thinking that first thing is that we need to make sure if the patient is mentally healthy to receive a secondary procedure. So if I don't think he is mentally healthy to receive a redo procedure, I don't think I need to take too much time to explain about his concern about the previous procedure. If I don't consider this could be a potential patient I'm doing a redo OGS, maybe a better way will be tell them that you are good enough, or you looks really fine. I cannot find something more I could do to help you. So the first step for me will be, I personally, of course, before seeing psychologists, if I personally find the patient has some like family support problem or mental problem, maybe I don't need to explain that much. And my personal principle is that like Professor Chen, we almost never uh, uh, I mean, encourage the patient or tell the patient that yes, the first surgeon is wrong, or the first surgeon does not doing anything good. So we will never. I think I will never do that. If I'm considering this patient will could be benefit from a redo procedure. Right now, I still do not refer the patient to psychologist. So I think later I will find a psychologist. And the second thing is I will just focus on my objective evaluation of the what's not good enough about the aesthetics, and then we need to we need to have an agreement that the patient's perception of suboptimal aesthetic outcome is quite similar to what I objectively observe. So this is very important to important decision or thinking that I should do in the first clinical visit. And based on reviewing these two articles, I believe that I should take several uh, clinical visits before the real surgical procedure. I mean, we should check the patient several times to before really made a decision to redo OGS. So it's different from primary. Thank you. So maybe Professor Chen could say something to teach us.
Yes, Professor Ray Chen, could you give us some comments about the redo surgery?
Thank you. It's very, very good review. These two papers quite differently. First, I think that's Percy's paper include quite a few real congenital anomalies, including so-called mandible elongation. He classified it, and early surgery in the early teenager, like 13, 15, 17, or before 20 years old. So it's a different group of patients as we see now. But we do have a group of patients of clefts who have some congenital anomalies. So it's quite similar in that way. Well, in our group now, I think it's more like the second paper from Italy, more aesthetic concern. And they do have a good protocol that they include the non-operative patients, but need secondary consideration. So if Dr. Yao will focus on the secondary redo surgery, I think you start to have some kind of patient's record regarding to the unhappy or unsatisfied OGS from our hospital or from outside hospital. So included why is not happy, and all this is a very good part. Well, if I will do the secondary surgery, as Dr. Yao said, and seems that we can focus on the different type of complaint, as the second paper said, or the other is that, as Dr. Yao have done some different so-called unhappy patients, like the unexpected fractured condyle dislocated and severe mouth opening limitation, or then to the so-called functional is aesthetic functional problems. And we do have some patients have some complaint about even the nose problem after OGS, and even some others like profile problems, asymmetry problems. So you think about it, how to classify it. And I think because we do have our referrals from mainland China or some other countries, but we do have a good chance to have very in detail classifying our so-called redo surgery patients. And according to your experience as well as in the future, I think we can have quite good publication as persons, or even better than the Italy's. So good. I see you are a very good start, and it's good points to focus on this redo surgery into your future.
Thank you, Professor Chen. And sometimes in our clinic, after previous treatment, because they probably have some skeletal problem, some orthodontic problem, dental problem, and then finally go through previous treatment. Usually they received some camouflage teeth movement. So after the primary treatment, the secondary treatment will become more difficult. So I would invite our orthodontic doctors to give us some input about how to evaluate and build up the treatment protocol or treatment plan for one patient that received a previous surgery, and then combined with complex treatment plan and camouflage orthodontics. Dr. Wang Yijing, Dr. Wang, can you give us some comment? Have you seen that some patient having had previous camouflage orthodontics, and also sometimes if, for example, some class 3 patients, they may having little reverse overjet, and then after the previous pure orthodontic treatment, it could be another type of difficult patient.
Okay. Dr. Lin, can you hear me?
Yeah, we can hear you.
Actually, I don't have much experience in reduced surgery cases. But recently, I have one reduced case. And what I did is I still need to do some pre-surgical also before the secondary OGS. And firstly, I coordinated the upper dental midline to the skeletal midline, and try to close all the space before surgery to reduce the complexity, reduce the difficulty in post-op orthodontic treatment, and this one well prepared before the second OGS. Just I think this make it as simple as possible to reduce any further problem after the second OGS, to reduce the risk. Yeah, and for those who have previous camouflage orthodontic treatment to in patient have scattered discrepancy, I think, like you say, the class 3 patient who have camouflage orthodontic treatment, sometimes because of the limitation of the symphysis bone, because they are usually quite thin, and so the retroclination of the lower incisor cannot be totally corrected, totally uprighted. Yeah, and so sometimes I because that will jeopardize the periodontal status of the lower anterior teeth. Sometimes we don't correct the retroclination completely, and we will sometimes, I think, because for those who with lesser negative overjet in those class 3 patients, we sometimes, I think, we still need do some pitch rotation, clockwise pitch rotation to help to correct the class 3 condition for those cases. But yes, but for those who for those, I think for me the more difficult thing is for the asymmetric case with previous orthodontic treatment, because they might previously do some orthodontic treatment to camouflage the midline, so maybe the lower dental midline is not already is not on the mandible midline, is not coordinated with the mandible midline. So sometimes I may spend some time to correct this part before surgery with pre-surgical orthodontic treatment, or do some arch expansion in the upper because the upper arch might be in a asymmetric shape after the camouflage orthodontic treatment. Yes. Thank you.
Thank you, Dr. Wang. Is there any further question or comments? Dr. Hashim, well, do you have some question you raised in the chat room? Well, you can open your microphone, then you can speak.
Hello, sir. Good morning. Good morning to everyone.
Yes, please. You have question?
Okay. My question is because some patients who are coming for second opinion, sometimes they are quite sensitive to referrals to psychologists. So sometimes those patients, even when we discuss the psychological assessment, they will just leave and they will never come back. So can we have like a scoring system, like a schematic form, which have some scores for the differential deformities, like if the patient will have enough score, we can just proceed to the surgery, or this cannot be convenient?
Oh, yes. And Dr. Yao, do you have some answer to this question?
I don't know. I believe there will be some score that we may utilize to evaluate the so-called psychological status. But I believe some of the diagnoses, such as BDD, that you should really see maybe we are just we just suspect, but you should have a definite diagnosis. But I think your question is correct, that you may push out the patient who comes to you. But I believe if you want to achieve a stable, consistent result, you should have a routine evaluation process. If all the redo patient group, they understand that you have this type of routine evaluation, they in the long term, I think they will be able to accept. And your question is that we, as a surgeon, we use some type of questionnaire to make the final decision. But remember that if you do this, you should be still 100% take the responsibility. Yeah, so that's my answer.
Thank you. Is there any further question or comments? If not, we thank you for joining this morning meeting, and thank you. The meeting is closed.